Good morning. Hopefully everybody can hear me. I do tend to talk a little soft. I am appreciative of this opportunity. Thank you all. Thank you, Sean. And so today I'll be talking about an evaluation of HIE's participation in the PCDH project Heartland Region Pilot, which is patient-centered data home. And we'll talk about that a little more in just a moment. And so just as to tell you what I'm going to do here today, I'm going to give you a brief introduction of myself. I'll talk about Patient-Centered Data Home Initiative. I'll do an evaluation of PCDH, and then we'll talk about some next steps. So first, I am, as Sean said, a postdoc fellow in the Public and Population Health Informatics in the T15 Informatics Training Grant. As you see, I'm way up there at the top. A few of us in here are on there too, but I am in that program. And so my research does focus on the system level informatics. I've been doing the evaluation of patient-centered data homes with Dr. Granis. I'm also looking at perspectives on the IMPC. I've been working with dental informatics, looking at some dental provider initiated medical consultations. Also the use of informatics in professional health education, so with the teaching EHR, also with some evaluation in the Center for Interprofessional Education. And so let's just jump right in. Patient-Centered Data Home, this new initiative, I'll tell you a little bit about what it is, but let's take a step back. So I'm sure many of you remember there was a time when you would go to the doctor and the doctor had your patient records. They were paper records. They were held at your doctor's office, and getting them to the next level was a little bit difficult. And so let's say you went to the emergency room, then the best way to get that over to them was either fax or by a courier. And so we could see that could take, I'm sure that would be a little frustrating for people in the emergency room as they had to wait for the courier for maybe a day or two. Fax, it could work sometimes. Sometimes you couldn't get all the information. Well, with the electronic health electronic health records, it became a little bit easier for hospitals that were connected, facilities that were connected with each other to share this information. However, that information still, in a lot of cases, was one way. You generally took a little while to get that information from these emergency departments or other places sent back to the primary care doctor. So with health information exchange, in this case, the organizations, it became a little bit easier. We have a different kind of setup so that it makes it a little bit better for different places to share information, have that in one solid place, so that patients can go to different places in their community, in their areas, have their health records available, stored at that health information exchange. The only issue with this is patients travel. So what happens when you go outside of your state lines? What happens when you go to other places not in your home area? Then it becomes limited data. You go back to the fax machine in some cases. Sometimes you just don't get all the data, or there's no data available to even, or you're not able to find the doctor, which state the doctor's in, things like that. So that leads us to the idea of this limited or no patient data. So the issue with that, for pre-treatment, let's say you walk into a hospital in a different state, and this patient-centered home or patient-centered care idea, it requires data for informed decision-making, not just for the patients, but also for the physicians. And so looking at that, needing that data is not available if you're over state lines and you're not able to find the doctor, things like that. The access and timely access to this information is important as well. And then thinking about diagnosing patients without the right information, safety can become an issue in emergency situations, crisis situations. And then post-treatment, so care coordination is lacking here. There's no, follow-up leads to return to emergency rooms, worsening conditions. It's a lack of surveillance in populations. There's high readmission rates, which we just talked about. And then physician being unaware of the patient visiting another facility. So these are some of the issues in which patient-centered data home is seeking to answer. And so it leads to this quest for national interoperability. And that quest is just linking these different health systems together so that patients can travel, patients can go anywhere, and their healthcare is available with the sufficient information needed to give the proper care. And so Patient-centered data home is not the only one on this quest. There's also this Sequoia project, eHealth Exchange. You also have the National Interoperability Collaborative, and there's also some vendor collaborations that are going on as well. And so with this national interoperability, the Office of National Coordinator for Health Information Technology, or ONC, they emphasized this need for national interoperability. In 2016, they decided to put out a funding opportunity for real-world pilots, and they call them high-impact pilots, which would fund projects to push along this agenda. And so in comes the Strategic Health Information Exchange Collaborative, also called SHIC. They have a 67 Health Information Exchange membership, which this is what they base their development of patient-centered data home on. So what happens is they took their membership of the different HIEs and they connected those to build this network of exchange. So as you see, you have the different regions. These are different pilots that are going on. So the Western region, they're attached in the blue here. And so this is what they did. They sought to do. So they started linking their own network of health information exchanges to facilitate that when patients come to go outside of their area to different places, that they would still be able to be alerted and exchange information. And so ONC actually funded the PCDH Heartland region pilot, and that includes those HIEs on the right side. So in Knoxville, Tennessee, you had Eastern Tennessee Health Information Network, was also in Michigan, Indiana, Kentucky, and Ohio. Excuse me. And so with this alerting and exchange network among these health information exchanges, there was this purpose of care coordination. So as I talked about in the beginning, this helps out a little bit with patients leaving hospitals, leaving facilities, and their physicians knowing nothing about them even attending a hospital outside their area. This also helps with the nationwide access to patient information. Using this existing community of health information exchange, they already have this trusted idea of working with each other. It's already a really good system set up. It also preserves local governance. They work together to figure out how to make this work the best way they can with each other. And then it also protects local stakeholders. It's not having their information just all over the place, but it is in secure location. And so let's talk a little bit about the process here. So let's say that you have a patient who lives in Kentucky. This patient has attended several health facilities. These health facilities in his area, in his state, they all send their information to the Kentucky Health Information Exchange. Their records are then stored in this in KHIE, and this is called their home HIE. So let's say the patient decides to travel to Indiana. Let's say they go to Indy 500. And if any of you have ever been to Indy 500, you know it's very hot. And so let's say patient gets a heat stroke. He is then life flighted to, because you know you can't drive out of there. So he's life flighted to the hospital here in Indiana. And at that time, he's there. Nobody really knows who he is. Maybe he needs some records. They figure out who he is. So they send a query to IHIE, Indiana Health Information Exchange. That query is then sent to KHIE to see if that patient has information available. If that patient does have information available, those records are then sent to IHIE and then to the hospital who's providing the care. At this time, the hospital will have those records available. They'll be able to do what they need to do. They have this information from all of his care in the past. So when that transaction is done, encounter is done, then that record is sent back to IHIE, which is then stored in KHIE in his home HIE. So then when he returns home, he has all of his records available in KHIE there. Even so, the doctors will be alerted. They will be aware that this information is available for them to follow up on. And so let's talk about the evaluation of this process using IHIE's participation in the Heartland region pilot. And so the methods we used as data collection was IHIE allowed us to use their data from the Heartland pilot. They use the HL7 admission, discharge, and transfer transactions, so ADT transactions, during December 2016 to December 2017. And so there's an example of an HL7 message. So we looked at these transactions, we parsed for the volume of exchange, sending and receiving facility, message date, age, gender, chief complaint, and visit type. We also use descriptive statistics in R and Microsoft Excel. And so this beautiful chart is the volume of exchange by sent and received health information exchanges. So approximately 1.5 billion transactions were conducted or sent and received in the Heartland region during this period of time. Now I'm going to explain this a little bit. So what this shows is the exchange both ways. So with IHIE, because we're specifically talking about IHIE today, they do have the most here in the purple. And it's sending and receiving. So hopefully I can explain this really good to you. So let's, for example, so men, what they did, because this is blue, that means that IHIE has sent the most records to them. And so it's the both way exchange. So in this case, IHIE has almost sent as many as men has sent to IHIE. And then in the case of, let's see the name, HealthLink in the orange. So in that case, HealthLink has sent more information to IHIE. That's why this particular flow is orange this way. And so that just kind of shows the flow of information that happened, the magnitude of exchange to each health information facility. So in this case, gender, it was more females, so about 58% to 42% males. And then the age category, majority was 56 to 75 years old in this particular population, traveling outside their home areas. And so as far as the patient visit type, we have outpatient being the highest percentage at 60%, and then emergency is next, followed by inpatient, others, which were like obstetrics, there were some patient and readmission in there, and then inpatient at 3%. So then by age category, and this did not show up as well as I thought, so we're looking at, for the age group of 18 to 25, we see that a majority of them visited the emergency room at higher rates, whereas 76 to 85, they more likely were in inpatient, showed up in the inpatient part of it. And 70% was the 56 to 75-year-olds in outpatient. As far as chief complaints, I'll just share a few of the top 5 overall of the exchanges, so almost the 1.5 million. Unfortunately, in this particular data, we had almost 55% of this category was blank or had like X or Z or random numbers and letters in them. And so with that, keeping that in mind, the top chief complaint was labs at about 8%. Next, we had screening, which was 5%, chest pain, shortness of breath was about 3%, and then fall was also 3%. So in discussion, we do find with this brief kind of overview of patient-centered data home that it is a practical and feasible way of exchange. We're looking at, with this quest towards national interoperability, this is just almost like the first step towards finding a way to make this possible. And so we find that it is practical and feasible. It does keep this comprehensive medical histories, and it supports this continuity of care. And so because all of the patient's records are stored in their home health information exchange organization, it is available to be queried and wherever they seek care. And so there are other potential values. There's you could improve interventions, knowing how patients travel and different things like that, increase public health surveillance, also a greater awareness of gaps in health, like where have we previously been missing this information? How does it fit into care for patients. And then, like I said, this is a step towards national interoperability. And so future steps, directions specifically for this research, I would love to classify and further analyze the chief complaints. So seeing which health information exchanges are seeing the different kinds of chief complaints, which age categories. So just break that down a little bit more. Also, the patient-centered data home is expanding with 32 new health information exchanges, and then with an additional 8 that are pending. And so just having that information, putting that all together, seeing how that changes, does it differ? Are we seeing the same trends across the whole United States so far? Those kind of things. And then also some patient matching. So in the same data, are we seeing the same patients traveling, attending, or seeking care outside of the state? Are we seeing patients who work in other areas? Just different questions like that. And then also merging data from the Western and Central pilot studies, which kind of goes with the second point, but just looking at more data, seeing, being able to look at a bigger picture, see what else is going on there. And so I am actually done. And so just a few acknowledgements for the T15 Informatics Training Grant. Also, Dr. Sean Grannis, my mentor, and a few of these lovely people who helped me. Also, IHIE and their team. Wonderful, thank you. That is all I have. Any questions? So. Yes, sir.
So I have a naive question. That guy from Kentucky went to a provider here in Indiana. How long does it take for the IHIE stuff to get to that doctor? Does he get it while he's treating him? It's that quick?
I appreciate you asking that because that was supposed to be part of my description. It is the real time. So it's, as soon as that query is sent, because it's almost like automatic, that can be sent immediately.
And what do they have to send? Is it just what kind of identifying information?
It is, the query is based, they have a setup query, like what needs to be sent to get that information. So it's like a template.
Well, I know that Sean has done a lot with our people on matching of records, and I'm just wondering what you need to make sure you get the right data back.
That's a very good question. We're still working on that, but feel free, Sean.
So the Kentucky guy goes in and they query IHIE, but what do they have to send? His name's not sufficient, right? Birth date and name probably isn't. What do they send in the query to get the right record?
You're asking what demographic, what identifying information.
Yeah.
So, the dirty secret is, everybody still uses MRN. So institution, identity, and medical record number are two powerful identifiers.
Right, but he's not going to know his medical record number.
So what happens though is when this person shows up here, right? They're going to be presenting at least name, date of birth,
Sure.
gender, right?
Right.
We found that that's good enough. If they're coming up here for some reason, they may have been here before, and we may have forms of their identity around already, so that additional information can also be returned. We accumulate data, just like the credit bureaus. We actually accumulate demographic identifiers on each patient who come in. We don't generally throw that information away, which is how we do a better job than just the average. So it's still a challenge, right? And if they send it, ideally we can get that Social Security number from them, and if that's the case, then consider it. But it is a challenge, no question about that.
Either one. Go ahead.
Oh, so good job, Karmen. I was kind of surprised. I was surprised by the proportion of visits that are outpatient, because our lovely illustrations of HIE focus on the emergency setting. I'm visiting my grandparents and or my grandkids, and I have an accident and I have to go in for treatment, versus the outpatient. So I'm wondering if you have or plan to look under the covers of those outpatient visits to understand what what types of visits they are. I'm imagining that there's a lot of folks who are making planned, scheduled visits with a routine provider outside of their typical marketplace, which is, I think, challenges our general assumptions about healthcare markets. So if you could comment on that, I'd appreciate it.
Yeah, definitely. I think that is something definitely that I want to look into. I think that it will also help when we start with the patient matching and looking at that kind of thing, just to see, is it the same patients going to these facilities for outpatient care, as well as digging deeper into what type of patients are going to these different areas. That would help with the, with looking more at the chief complaints, that'll help with a little bit. But yes, definitely plan on looking at that further. Oh, sorry, Titus.
Thank you. So my question is about what will you have learned and what's the impact of the final results of your study? Like, how is that going to inform something else, or what's the next step?
Thank you. I think the next step, definitely it begins to, I really had to think about that, I think, a little bit. I think the next step it's going to help with patients being connected, having this information available wherever they go. And that being said, it's going to be helpful for patients to get the proper care wherever they seek care. In addition, I think it's going to help with facilities and healthcare facilities and different states just coming together, realizing that, I don't know why I said that, but anyway, coming together and really beginning to work together to build a better health system overall. I think it's kind of the first step to having better, just better health in America in general.
Yes. Yeah. So, part of what we're doing here is we're measuring the mass of the electron. And what I mean by that is this type of circumstance, this type of setting, frankly, has been analyzed before. I mean, this is an incredibly unique circumstance where you have HIEs connecting together. So just describing how do they function? What does the flow look like? What's the nature of this work? So I call that measuring the mass of the electron, because you're basically just describing this thing that we really haven't seen before. So that's number one. Number two, we have some hypotheses. Like, we hypothesize that people like drug seekers may be moving not only across multiple institutions within our HIE, but outside of that. And so we presented some preliminary findings earlier that showed there were about 1,000 patients that were moving outside of HIEs with pain and opioid-related diagnosis. So that's one example of something very interesting. But think about any patient movement question over geography, I think, is ripe for exploration here. So I would suggest that this is almost like an expanded form of health information exchange, and I think it presents a lot of new, interesting types of questions that we could be asking that generalize from our own HIE to others. So again, I think it opens up for creative people a lot of potential new, and it's a new laboratory, I think.
Yes, sir.
So I wonder if you can help me with something that I was, as you presented your numbers, I didn't have a sense of the magnitude of the exchange relative to care that's being delivered, or people that exist in the different HIEs. And do you have some, you said there were 1 million and some exchanges during a particular window of time, and I was going, well, that doesn't mean anything to me, because I don't know, that could be 1% of the patients who are seen, that could be 90%. I don't know. Do you have some sense of that?
I don't. That's a very good question. I'm going to pull that out, though. I don't know specifically. Yes, sir.
I'm going to have a follow-up question very, very similar to Steve's way of thinking in terms of the volume, while very impressive, can't necessarily be confused with meaning. And, we commonly present exchanges of having this huge volume of transactions, but we need to be able to extract meaning in order to make decisions. And so some thoughts about how to kind of populate this. I mean, some of the meaning is probably in the CCD in terms of the specific lab tests, specific medications, but even the chief complaint, in order to understand like, what does this presentation with chest pain represent across this population? You need to establish the denominator of the population, like what hospitals are participating, what patients are being seen at those hospitals. And among those who are being seen for chest pain, how many are appearing in our data? Oh, and furthermore, of those reporting chest pain, is that in our data, is that a true positive? What did that chest pain really mean? Or, was it just something they checked at the top of their list? So really, from a public health perspective, defining that numerator and denominator, almost like a sensitivity specificity thing, will get you closer to this data element means this, and now someone else can use it too, because I've defined my measurement tool.
Okay. Thank you. Yeah, I think that provides a really good opportunity I hadn't thought of. Yes, sir.
So, I was wondering, as you think about the emergence of national networks, do you see or foresee issues related to patients' consent to have their data shared, or is that taken care of already sort of at the regional level?
Yeah, that definitely, with that idea of them honoring local governance and local consent and things like that, that is something that patients can opt in or out of through their local IHIE. HIE. I said that backwards.
So, Karmen, I think you may have alluded to this briefly, but can you say a little bit more about what you're doing with chief complaints and what next steps are with chief complaint analysis?
Sure. Yeah, I like this idea that Dr. Downs and the gentleman in the back brought up of just looking at what type of patients are going where. So what chief complaints are showing up and with which health information exchange and with which patient class. So who's showing up for outpatient, who's showing up for emergency room, inpatient, things like that. Just dig deeper on that. As well as looking at just the age groups. So are we seeing mostly certain age groups going to certain facilities for certain types of care? So just looking more into those things.
Can I just make one comment here, which is when IHIE first started, we had lots of these little animated diagrams that would show IHIE and then would expand to the map of the United States and would show the idea of multiple nodes connecting. I just want to comment that it's really exciting that this is actually happening the way we predicted it would happen, 6 years ago, 7 years ago. And I'm glad you're on it. Thanks for sharing.
Thank you. Yes, ma'am.
What proportion of the physicians were actually aware of this within the IHIE network?
You said, are they aware?
Yeah, that they knew it was available. I mean, that's the first thing, right? If they don't even know it's available, they wouldn't look for it.
That's true.
Was there any publicity when it was set up?
There was publicity. I'm not sure as far as the extent of it, though. Anyone have any idea? Feel free.
I know I don't have the answer to that question either, but Sio's question stimulated another question, which is, how did the physicians, what was the workflow? Did they have to go to 2 different web portals? Was this ingested into CareWeb so I could see it in CareWeb as a clinician? Like, how did I see the data from the various places?
I'm going to see, Sean, do you have any idea about that?
So each HIE can opt to display this data in different ways. So if you've seen one HIE, you've seen one HIE. So how these get displayed in the individual workflows of the different HIE is up to those HIEs. And frankly, again, part of what makes this exciting is if there's anybody with an interest in workflow and usability, this is literally, we're describing the plumbing here, folks. I mean, and we're at the ground level of being able to influence this. So every one of the questions, from consent to usability to data to analysis, they've just proven that the plumbing works and things aren't leaking and that the water tastes good. But I mean, this is literally the formation of the laboratory to study stuff like this. And so I think it's going to create a lot of potential opportunity. We are leaders in health information exchange evaluation, and innovation. This, I think, is one of the next epochs in our work here. And most of the questions that you're asking, admittedly, we don't have good answers to. Why? Because we're at the beginning. And so I hope that this is exciting enough for several people to want to explore and pursue this further. SHIEC, the organization, Strategic Health Information Exchange Collaborative, they're beginning to get really excited about this. They're starting to think about the potential, and they want to work with organizations like Regenstrief to think about how this can be evolved and grown and expanded and enhanced. So this is a great conversation. These are great questions, and I think it presents a lot of opportunity.
Thank you. Anyone else? Yes.
Karmen, I have zero scientific expertise, but I am a visual communicator, and I just wanted to compliment you on the excellence of your presentation. And Sean, as you said, you're at the ground level, and you've done a great job visually communicating all the concepts for people.
Well,
great job.
You. I appreciate that, and thanks to Sarah for that as well.
Other questions for Karmen?
Yes.
It's a great presentation. I have one question though. So we are talking everything between hospitals and healthcare organizations. Do patients right now have access to this information, what is being stored behind them? They might have two different portals of those healthcare organizations, but do they have something from the IHIE or the information exchange? And can patients become, as we take health, but the patient center data home, can it become part of the curation of this data and add more to that?
Thank you for that question. Sean, I'm going to refer again.
So the patients do not have direct access to either IHIE data directly or the patient-centered data home directly, but that is an area where we would certainly like to see the science and the process advance. We do think that consumer-mediated, consumer-involved healthcare is a very important part of the future of healthcare itself. And I know, and I'll leave it to IHIE to say more about this, but they are making plans to ensure that IHIE's infrastructure is capable of supporting patient-centered approaches. So, yeah.
Thank you. No, great.
Hey, Karmen.
Hey.
So this is all based off of a set of like ADT transactions, which are perfect for exactly what you're doing, describing the plumbing. What's the next like set of data that you want to get your hands on from this to sort of further the next step of this research?
Sure. Definitely. I know they're starting to exchange CCDs and I would love to look deeper into some of those to see what is, get a deeper understanding of what's going on with these exchanges. So that is one next step.